In this programme, we look at a fierce debate about how to treat children and adults with gender identity issues.
I shouldn't have done it. I shouldn't have made the decision. Others shouldn't have allowed me to make that decision.
The two most experienced doctors involved in transgender care in Ireland accused the HSE of bending to the demands of transgender activists and promoting an unsafe model of care for children. Primetime has learned that the doctors who founded the National Gender Service have in recent weeks taken the unprecedented step of lodging a formal complaint against the HSE with the health standards watchdog HIQA. The doctors allege that the HSE has directed children from Ireland to gender clinics abroad which adhere to a model of care that can harm children, an allegation that the HSE firmly denies.
I think that the HSE is committed to an ideological model of care for gender health care. We have made numerous efforts to engage the HSE and inform them of the risks.
People who have transitioned, who are now saying, how did that happen? Why did that happen? Why was that let happen? Why wasn't I given more time? How can I be 22 and this has happened?
There are deep divisions about how to treat children and adults whose gender identity doesn't match their biological body, a condition known as gender dysphoria.
If I don't come in from a compassionate or affirming approach, you're done from the get-go, as far as I can see.
Many trans rights activists believe in what they describe as a patient-centred approach.
The patient-centred care model suggests that the clinician presents the options, presents the risks, and then allows the patient to make a decision.
The division comes at a time when growing numbers of young girls in particular are suffering distress because they wish to become boys.
I was disgusted with my body. I hated being a girl. So I believe that if I was a boy, I would be happy.
Across Europe, there is an intense debate about healthcare for the surging numbers of adults and especially children who are coming out as transgender. This debate is not the same as the so-called culture wars, often waged on social media using intolerant language. This debate involves people who are serious about healthcare, but it is also heated. The HSE told Primetime that relations between it and the National Gender Service, which treats adults, are not good. Here in England, the debate led to a deep and ongoing review of the specialised service for children with gender identity issues and a shutdown of that service to new patients. That matters for Ireland because that service is where the HSE referred some of our most distressed and vulnerable children. Many with gender identity issues enjoy successful transitions which can involve a number of treatments, and not every patient has them all. Children in early puberty may take a medication called puberty blockers to stop their body changing. Those over 16 may be prescribed cross-sex hormones, estrogen for boys who wish to have a female body, and testosterone for girls who wish to have a male body. Over 18s may opt for gender-related surgery such as testicle removal, mastectomies or vaginoplasty. Only some of these surgeries have been available in Ireland. Before embarking on any treatment, patients are assessed. The quality and thoroughness of this assessment is at the heart of the transgender healthcare debate.
When properly assessed and prepared and appropriate, medical treatments for gender dysphoria are very good and we see very good outcomes. However, if other problems that the child has experienced or the adult are not addressed, it can exacerbate those problems.
Some may socially transition, which means they live life and present themselves as the opposite sex without any medical or surgical interventions. Usually, the earliest available medical treatment is puberty blockers, which are controversial. Some countries, including Sweden and England, have recently restricted their prescription, but previously they were commonly prescribed to pause puberty with the intention of giving children time to think about their gender.
In fact, it turned out to be the opposite was the case, that it created a sense of urgency to proceed on to cross-sex hormones, and because of the complications of leaving people on blockers too long, clinically the risk of bone disease meant that the doctors were under pressure to make a decision.
If you suddenly become aware of the fact that maybe you're becoming a sexual being, that day is coming, not quite yet because you're 13 or 14, but that it's coming, then that is quite a distressing notion. And so if people are telling them, yes, you do not have to go through this puberty, you do not have to grow breasts, you don't have to develop into a woman, that can feel like a really good answer to where they are.
Prior to the use of blockers, most gender non-conforming children through puberty became comfortable with their bodies and assigned gender. Once we start blocking, we find most of the children will proceed onto cross-sex hormones.
In recent years, there has been a surge in the number of children who are questioning their gender identity. A survey by the Children's Ombudsman's Office last year of 12 to 17-year-olds suggests that 1 in 25 identify as non-binary. That means not solely a boy or a girl, or as having a gender different to their biological sex. That would equate to just over 21 students who are gender questioning in the average secondary school across the country. The issue is becoming more commonplace for GPs in cities and towns.
A very large number of adolescent girls are coming in a distressed state looking for help, and they're in a lot of pain and they feel that they're in the wrong body. And that's what they will often say, I don't want to be in this female body, I don't want to be a girl, I'm not a girl, I'm a boy.
It's a greatly changed landscape since 1996, when Donal O'Shea first began working in trans healthcare.
The first patient I saw day one in Charing Cross Hospital, mid-40s, trans woman, fully socially transitioned, flamboyantly dressed and delighted with where they were on the journey. And that turned out to be quite typical of the time. And now it has changed to a much younger and much more likely to be a female transitioning to male.
A 16-year-old who we are calling Sinead was once one of those girls. She believed she would be happier as a boy.
I started questioning my gender identity in primary. I was bullied a lot, so I had very low self-esteem.
Why did you think that being a boy would solve your problems?
I believed it would solve my problems because I was disgusted with my body. I hated being a girl. So I believed that if I was a boy, I would be happy.
Sinead started to openly identify as trans in secondary school, whereas before she had few friends, she found herself accepted by a wider, supportive group of like-minded pupils.
About 10, 12. A huge group of just everyone trans in a massive group. And they'd even have meetings, the LGBTQ, but it is just the T, trans.
And so that group of 10 is within the same school?
Within the same school, yes. All hang out at lunch, different years.
Like many of those coming forward with gender identity problems, Sinead has autism. Figures from the Tavistock service in England, where Irish children went for specialist assessment, show that around 1/3 have autism or other neurodiversity. Cambridge University research shows that the rate of autism in transgender and gender diverse people is 3 to 6 times higher than the wider population.
Most of the people coming to us have associated mental health or functional problems. 10 years ago, most people did not, and they were much more ready to commence medical treatment. Now we see people who are having huge difficulties, maybe going to college, going to work, even leaving their bedroom. We see a lot of people who have autism and also have gender dysphoria and are suitable for hormone treatment. They are not mutually exclusive situations.
People who are neurodiverse don't develop at the same pace as people who are not. Well, if individuals have undergone either hormonal treatment or surgery that has rendered them permanently incapable of having children, there are many trans people who have transitioned, hit their late 20s and gone, God, why did I do that? And why was I let do that?
Plenty of people who have autism and are perfectly functioning and doing many things in life. Just because someone has autism doesn't mean that they aren't able to make decisions like that around hormonal treatment. So it's not as simple as saying you've got autism or you've got a mental health issue, therefore you're not suitable. It's much more nuanced and complex.
As the typical patient has changed from older male to younger female with autism or other issues, reliable research is lacking on treatment outcomes for this newer cohort. In the past, however, research has shown very low levels of patient regret over gender-affirming treatment. But Richie Hearn, who lives in Northern England, is an extreme example of what can go wrong. Suffering significant mental health difficulties, the civil servant believed that the reason for his distress was a mismatch between his gender identity and his biological sex. He had been taking cross-sex hormones and had been living for around 4 years as a woman before he had what is called gender-confirming surgery.
It was 2 days before my 31st birthday. I had a penile inversion with scrotal graft. What that means is they remove your testicles, they remove most of your penis, they take obviously the muscles out, and they create a cavity in your crotch.
Now detransitioned and once again living as a man, Richie immediately regretted the surgery he had consented to.
I think my expectation was I'd wake up with that sense of relief and elation and clarity, if you will, or being whole and everything that you've seen in all the videos when they're waking up. Like, I'm so happy, I'm a woman now and all that. I just felt dread. I felt absolute dread. It was like, I have messed up in a way that is stupendous. No one can mess up like this. No one. I have really done myself a huge disservice. Why did I do this?
Since the operation, Richie has had recurring problems and pain.
And it's not just losing the body part, but the replacement isn't anything that you think it's going to be. And it's full of issues, full of problems. It makes it very, very difficult to know when your bladder's full or empty, and there's a lot of toilet visits. And there's also like this residual sort of leakage going on.
Now 36, Richie is suing the NHS. He claims clinicians didn't properly probe whether his mental health difficulties, including a diagnosis of obsessive-compulsive disorder, may have been the reason for his obsession with becoming a woman.
I think it took a team to get us there, including myself. I'm part of that. I'm always upfront to say that obviously the responsibility does lie with the individual, but if you've got a known addict going to a doctor asking for pain meds, the doctor will say no because they're a known addict and it's not going to help them. So why does that happen here? You got somebody who's very mentally unwell asking them to take parts of the body.
In a statement to Primetime, the NHS said it couldn't comment on an individual's care and treatment, but said that all treatment decisions are made following a thorough assessment with checkpoints built into the care process. The care Richie received is called gender affirming, which is where a clinician accepts a patient's own declaration of their trans identity. This is generally the preferred option of trans activists. We requested an interview with Transgender Equality Network Ireland, TENI, to get its view of the gender affirming model, but they did not accept. They suggested we speak with Trans Healthcare Action.
Gender affirming care, to be really, really clear, what we mean by that is that we take a person at their word at a given point in time. So, if you meet someone and they say, I identify as female, I want to explore that, that's great. And then 6 months later, you have another consultation or whatever. You meet them because it's flu season down the line. The GP meets them and say, actually, I've decided that, I'm a boy now. And then, you meet them a year down the line. They're like, actually, I think I'm gender fluid. You have the treatment options based on that. You understand that community. The gender affirming care it doesn't necessarily mean that you force someone into a transition. I think that's potentially a misconception here. What it means is that if someone wishes to proceed with a course of transgender care, that they are supported in that. If someone wishes to stop a course of transgender care, it means that they're supported in that.
If I don't go in and respect the young person from the get-go and use their name, use their pronouns, speak to them on the level where they can feel respect, they can develop trust with me, then I'll just get a barrier, I'll just get told things that they think I want to hear, and the assessment will go nowhere.
The gender-affirming approach was typical of England's now controversial Tavistock service, which assessed children from Ireland referred by the HSE, and where Dr. Aidan Kelly worked as a clinical psychologist.
You speak very differently to a 12-year-old than a 16 and 17-year-old. So how old is the young person? How experienced are they in the world? Are they locked in their bedroom, online, or are they out with their friends, going to school every day? How able are they to kind of articulate and explain why it is that they think this identity, which is different to the one, the gender they were assigned at birth, why is it that they think this is a better way of explaining and identifying who they are? How do the people around them understand how this evolved and developed over time? What other needs may there be, whether they be mental health, neurodevelopmental, social, or whatever they might be? If someone wasn't a judge ready for treatment, then they wouldn't have gone forward for treatment.
Central to the affirming model is informed consent, which gives the patient more say in deciding treatment.
Patient-centred, gender-affirming model means that doctors, patients and their parents should work together as a team. They should have a trust relationship. They should understand the patient's needs at any one given moment. The doctor should then say, here are your treatment options. Here's all the information you need to know to proceed with those treatment options. And then, the patient should be supported in whatever decision that they make. This is kind of like supporting a child who wants to learn a language or an instrument. It is very...
So sorry, yeah. Would it be the patient then that would be deciding whether or not they take medication, for example?
Absolutely. And
even if the clinician is recommending against it?
It's absolutely the patient's decision. The doctor can make a recommendation, but it should be up to the patient to decide on their treatment path.
Clinicians at the National Gender Service in Dublin, including Donal O'Shea, who's better known for his work in obesity, use what is called an exploratory or questioning model of care. They say the gender-affirming approach is fundamentally unsafe.
It is driven by the patient. They use the term informed consent, which is the patient has informed themselves and consents to the treatment. That's not the informed consent model that works in medicine that we're obliged by the medical council to adhere to, where we inform the patient in detail of the risks and benefits and then make a joint decision.
Richie Herron believes that he would have benefited if his clinicians were less affirming, and warns against what he sees as the shortcuts of the affirming model of care.
Some people are getting rushed through this. It is not the be-all and end-all. That doesn't therefore mean no one should be able to access it, full stop. It means that there are problems here. There are massive problems. We're not treating patients like we should be. There's a lot of ethical concerns. And I think the knee-jerk reaction is there's so many people waiting for this, we need to speed it up. No, you don't. You slow it down. That is the answer. Not speeding it up. Speeding up will create more people like me.
When Irish schoolgirl Sinead identified as trans, she found much of her affirmation online.
Mostly got all these tips from influencers. We'll be taught how to talk like a guy, how to walk like a guy.
If you do want to actually do some voice training to help make your voice a little bit deeper, please do it properly and be safe about it so you don't cause any damage in this area of yourself.
So I would do these voice exercises. I'd go out into the shed and I would start like low humming up and down. We would get advice on how to come out. That was a huge thing. And to come out as non-binary first before you come out as trans, to like break the news subtly, I guess. But to also do not come out to transphobic parents, never speak to them, try to not talk to them as much as possible because it's just harmful to your mental health.
During this period, Sinead was self-harming and was seeing a child and adolescent mental health services, or CAMS, psychologist for ADHD. Her autism was at that stage suspected but undiagnosed.
I was going to a therapist at the time for anxiety and autism and cutting, which I would just go to her and I would just complain about my parents being transphobic the whole time.
Writing to Sinead's GP, the psychologist referred to Sinead, who was then 13, as a boy who disclosed a feeling of being misunderstood by his parents. In the letter, the psychologist wrote that the whole family are trying to adjust to his gender transition. And in their meetings too, the psychologist affirmed Sinead's identity as a boy. To Sinead, the fact that a professional affirmed her belief that she was a boy was important.
That's basically being diagnosed as trans. So when I realised that, oh, I really am trans because a professional told me so, I cut my hair, I got boys' clothes from the boys' section, I wore boxers, and I was just going down a rabbit hole.
Literally overnight, it was like she'd got a stamp of approval, and within, I'd say, 3 weeks, she cut off all her hair, literally a blade 3 with a little bit sprouting on the top.
In one meeting with the psychologist, Sinead revealed a traumatic time when she was sexually touched by another young person. Once Sinead's mother learned of that revelation, it was a turning point.
Once I found out what that entailed and what she had been exposed to, it made perfect sense to me why she would hate her body and feel revolted by anything like to do with, being a girl. We properly discussed, what she'd been through, and we properly started discussing about the potential that she was autistic and she needed a diagnosis. So actually, our relationship started to get, overnight, it just was really good. I don't know why. I suppose even to discussing gender identity till it came out our ears, literally, hours and hours of it. I suppose we just reached a certain understanding and respect.
When she started questioning all about trans, so I would start explaining it, and then she'd start pointing out the contradictions I was making in my own sentences. I started realising it myself, and I guess that's when I got a chink of doubt. Maybe there's something not right. Maybe there's something wrong. I still believed I was trans, of course.
But a new process of gender questioning had begun for Sinead. By the age of 14, she decided to cease identifying as a boy.
I'm really happy my parents were not affirming. So I am so happy that I did not take hormones. I have a healthy body. I did cut my hair off, but it can grow back.
Had Sinead pursued her gender transition, she probably would have been referred to the Tavistock Clinic in England, where clinicians generally followed a gender-affirming approach. Until last year, children were routinely referred by the HSE to Tavistock. Referrals from Ireland rose from just 1 in 2012 to a high of 46 in 2019, before dropping to 14 in 2021 during the pandemic. As of last year, there were 101 children from Ireland on the Tavistock waiting list.
What we were beginning to see in the mid-teens, 2016-17, was individuals being referred to us who'd gone to Tavistock and who were coming to us as young adults. They were clearly not ready for the hormonal phase of their transition to start, but that had been started. Individuals that we did not think were ready were well underway with their transition and having great mental health difficulties as a result of that.
In March 2019, Paul Moran wrote to the HSE, CCing National Gender Service colleagues, including Donal O'Shea, requesting that the HSE stop referring children to the Tavistock. Terminating the Tavistock service as quickly as possible was a key priority, he wrote.
So we had asked that they stop referring people to Tavistock back in 2018, 2019. We said it has to stop. We're seeing the problems coming back.
However, the HSE didn't stop referring. In 2019, National Gender Service doctors did an audit of 17 patient files of teenagers who were seen by Tavistock as children before being referred to the adult NGS in Dublin. In 7 cases, the audit found no record of a proper assessment, which should have included detailed patient histories and reasons for treatment decisions. 9 of the teens had been prescribed puberty blockers or cross-sex hormones, but in 8 of the cases, it was unclear from the documentation whether they had been prescribed medication at all. In 10 of the 17 cases, patients had mental or neurodevelopmental issues such as autism or ADHD, but in another 6, it was unclear from the files whether there were such problems, the audit found.
Well, that audit told us that we were sending our young people to a very inadequate service. And we wanted that data to go and show HSE why we had to stop the Tavistock thing.
And that was ignored.
And that was ignored completely.
We were consistently ignored.
The HSE may have ignored them, but the audit didn't go unnoticed. 2 years later, the National Gender Service's Paul Moran received a complaint from the HSE that sharing the audit with a senior doctor from the HSE was against data regulations. The sharing of this information constitutes a data breach, the letter said.
I found it strange that, having sent them important information, they showed no interest in understanding that or responding to the concerns, and simply wanted to make difficulty for the doctor who was in good faith trying to tell them something important.
Responding to the HSE complaint, Paul Moran's employer, St John of God Community Services, stated that not only was the sharing of the audit not a data breach, but Dr Moran had a legal and ethical obligation to share this information. The Tavistock's Gender Service for Children closed to new patients last year after reviews by the Care Quality Commission and by paediatrician Hilary Cass highlighted concerns about the quality of care. The Cass review noted that staff said they felt under pressure to adopt an unquestioning affirmative approach at odds with the standard process of clinical assessment and diagnosis. The HSE declined repeated requests for interview, but in a statement it said there have been no complaints from families who have used the Tavistock service. In its statement to Primetime, Tavistock said that we acknowledge the issues described by the Care Quality Commission and that NHS England has decided to implement a new model of care. It also said it works thoughtfully and holistically with young people and that only a minority go on to access any form of physical intervention at their service. Contrary to the gender-affirming model, Ireland's adult-only National Gender Service operates a so-called exploratory model that they say is more comprehensive and includes a stronger role for psychiatry. But activists say that it pathologises or wrongly medicalises gender dysphoria.
If you want to be referred for gender confirmation surgery in Ireland through the National Gender Service, you have to undergo a further at least 1, sometimes 2 or 3 interviews. Those are very in-depth and they talk in very specific and graphic detail about your sex life, what sex acts you enjoy, and how the surgery is going to impact those. That depth of conversation is unnecessary.
Presumably the clinicians would say that they're exploring as deeply as possible because of the effect of this surgery, to make sure that it is suitable for the person.
And I would turn that around and say, what other surgery, what other medical procedure do you have multiple in-depth interviews before you proceed with it? Do you have an in-depth interview with a clinical psychologist before you get an appendectomy? Again, it goes back to that stigmatising, that pathologizing of transgender healthcare, to say that it's something other, to say that it's a mental disorder, to say that it's something like that, when it's not. It's just a matter of day-to-day life.
Transgender rights groups have protested the National Gender Service NGS model of care.
I'm supporting Transgress the NGS in their picket on the Department of Health.
Because I know who I am, and the state shouldn't be able to tell me otherwise.
This bitterly fought debate has also reached into Ireland's conference halls. During the pandemic, a long-time transgender rights advocate and former TENI employee spearheaded a bid to bring the EPATH, European Professional Association for Transgender Health Conference, to Killarney.
It's a situation that I never thought in all my life I would find myself in, that I'm travelling to Gothenburg in the middle of a pandemic to bid to have a massive international conference in Ireland. Incredible stuff.
Vanessa Lacey had hoped to invite 2 clinicians from the National Gender Service, including Paul Moran, to speak at a meeting she was supposed to chair. But the conference host, Transgender Equality Network Ireland, or TENI, objected. An email from EPATH president to a clinician at the National Gender Service said, "TENI asked us not to invite yourselves as speakers to the public session, and we agreed."
How are we going to achieve getting people into the room if we're putting barriers up to them, speaking at these events? Both of them clinicians have a wealth of experience here. They probably work with more transgender people in a clinical setting than anybody else in Ireland. So, setting aside free speech, I think they had the qualifications to be able to sit at a public session for EPATH, in my opinion.
In protest, Vanessa Lacey resigned from the board of EPATH and walked away from the conference she had lobbied to bring to Ireland. Do you even attend the conference in the end?
No. I felt, personally, I felt maybe I shouldn't be there.
That must have been a difficult decision.
Of course. I mean, absolutely.
In a statement, TENI said it did not wish to invite the National Gender Service clinicians because it did not feel there was anything to celebrate about the Irish service. It said the NGS operated an outdated psychiatric model that causes distress and raises concern across the trans community. The HSE recently advertised for a clinical lead for children and adult transgender services in Ireland. Whoever gets this job will have to work on developing a model of care. The government, however, seems to have made up its mind already. Along with a pledge to progress the development of national gender clinics and multidisciplinary teams for children and adults, the programme for government contains a pledge to create and implement a general health policy for trans people in line with WPATH guidelines. WPATH includes non-clinicians on its board and promotes gender-affirming care.
It doesn't surprise me that the WPATH model is in the programme for government. The activist agenda in this trans space is dominant within HSE to the point that they are ignoring completely our advice based on clinical experience over 25 years that the activist agenda is resulting in harm.
In its statement, the HSE defended its practice of working closely with transgender groups, saying it includes service users and patient representative groups in the development of models of care in various areas. In fact, activists say that instead of causing harm, the gender-affirming model relieves distress for young people.
Transgender youth, transgender adolescents who receive gender-affirming care, they report better body image, they report better self-confidence, and they report better overall mental health after receiving care than before.
After the closure of the Tavistock to new patients, the HSE wrote to all 101 children who were on the Tavistock waiting list to advise them of a clinic in Belgium. We asked the HSE why it had picked this specific clinic, even though it told Primetime that the quality of care at the clinic was not assessed. In its statement, the HSE said it became aware that this clinic was accepting patients under its public health system, and it said it does not recommend the service. It simply informs patients of the availability of that public service. It also said it has no role in evaluating or otherwise approving a public healthcare service in another EU country. The Belgian clinic too declined a request for interview, but it told Primetime that it adheres to WPATH guidelines.
The Belgian model of care remains to be an affirmative care model, unlike its neighbours of France, Denmark, Finland and Sweden. So I have concerns about that, and even though our numbers are low, one child who is medically transitioned inappropriately is a disaster for that child, and I think we have to proceed with caution. Look at the countries who are saying stop. Finland, Sweden, Denmark, France, they're not noted to be socially conservative states. They're saying we're now looking at the evidence and we're actually changing our model. And that's the ambitious, that's the correct thing to do.
We requested an interview with Health Minister Stephen Donnelly, who has previously met with National Gender Service clinicians to hear their concerns, but he was unavailable. In the meantime, there is no functioning public service for children in Ireland with gender identity problems.
There's no public service in England, there's no public service in Ireland, there's potential to be re-referred on to the adult service here, but the waiting list for that is so long that you will be an adult by the time you get seen.
Although the Tavistock is currently closed to new referrals, our reliance on our nearest neighbour will remain. The HSE said it aims to refer children from Ireland to the post-Tavistock services planned to open in England next year. The model of care to be used by those services has yet to be decided. The HSE also says that claims that it has promoted a model of care that may be unsafe for children are not true. The National Gender Service clinicians who spoke to this programme say their HIQA complaint is just the latest move in an ongoing battle.
The core issue that I'm speaking out about is the safety of children and ultimately the long-term effects of poor care.
If there weren't so many young people potentially being put in harm's way, you would just say life's too short and move on and fight other battles. But you can't really let this go unchallenged.